Thank you. So I guess before we dive into this important topic, I'd like to give you an overview of what we'll cover today. Sexuality after brain injury is complex and often overlooked aspects of recovery. In this presentation, we'll explore this topic from various angles, combining personal experiences, community insights, and clinical perspectives. Our journey today will take us from individual stories to broader implications and ultimately to strategies for positive change. So let's begin. So my name is Saran Chamberlain, and if someone asked me to describe myself before January 2013, I would have said I'm a workaholic, I'm managing an international software company, I'm a gym junkie, and I have a great partner and 3 wonderful, most of the time, children. And I also enjoyed a great night out. So on 19th of January though, I was reduced to a stroke survivor. I never actually lost consciousness during this time, but I ended up with hemianesthesia and hemiplegia on my left side, and still do, so I still have no sensation on my left to this day. I considered myself being lucky because basically I could still remember everything, so I kind of just looked at it as in I was just paralysed. I was like, that's all right, my brain's still fine. They said that I'd be at Royal Adelaide for 4 weeks and rehab for 3 months, and I managed to get out in 8 days and 3 weeks, so it's pretty stubborn. Still am, which is probably what helped me. But what I didn't realise, I guess, you know, the thing was that they made me walk, which of course was important to be able to get me independent and that kind of thing. But what I didn't realise until much later was how many things weren't discussed with me after my stroke. The unseen, and in many ways the unspoken. So today I want to talk about a couple of those things, which are sexual identity and mental health. So my partner and I, which you can see in the left box there, had been together for 10 years before, like when my stroke happened. And we had a pretty good sex life, you know. But after the stroke, it became non-existent. My partner was amazing and really prioritised my well-being, but he wanted to do anything that he could to make sure that I wasn't in pain. So obviously anything to do with sex was like off the table, which, you know, was really lovely. But we didn't talk about sex, and no one spoke to us about it for a good couple of years. And when we did, and we finally tried, he was so careful and so conscious about not hurting me, and, you know, I kind of likened it to, I felt like a bit of a whale, just kind of, you know, rubbing all, like, you know, all over the bed because I had no control. So it was very attractive, you know, but I felt like a failure. You know, for me, I even told him that he should hire someone to, you know, do what he needs to do. But, you know, again, something quite different that I have seen from others' experiences. He was like, look, I don't want to have sex with someone else. I want to have sex with you. And when we do it, it's fine. Like, it's perfectly fine. Which, you know, still made me feel really bad. But, you know, this isn't a common story. And what I hear from other survivors of brain injury, like many have lost their loved ones, and not just that loved ones, but their sense of identity. General identity is important, but so is sexual identity, and that's a big part of someone's life, everyone's life. So today, 11 and a half years on, my partner and I are still really cautious because he's worried about hurting me. He knows I'm in chronic pain constantly and still doesn't or won't talk about it. This is 12 years on, and I'm doing stuff like this, although he's not here. So, you know, I'm like, do you want to hear my presentation? Like, no. So anyway. So here is what we do know. Sexual function is a vital part of quality for life of adults, but sexual dysfunction in individuals after an acquired brain injury, ABI, is a common yet under-recognised complication. It's often overlooked by both patients and clinicians, even though it could significantly affect recovery and relationships. So up to 50% of people experience changes in sexuality after an ABI, and these changes can really impact their quality of life and relationships. Now, while clinicians understand the connection between ABI and sexuality, it's often not addressed as much as it should be. Why? Well, you know, there's a mix of individual things at play here. There's that individual discomfort and some deeper institutional factors at play. The causes of post-ABI, TBI sexual dysfunction are complex. They involve a combination of anatomical, physical and psychological factors. Now, I get that sexual function might not be the first thing that comes to mind when we think about rehab, but it's actually a key part of a person's functional recovery, and a full return to sexual function can be life-changing. Oh, that's all right. Oh, no, it wasn't. Oops, let's go this way. This way, okay. So in 2021, I spoke about sexual identity and intimacy as part of the Genius network. Genius is a brain injury support group created by Cal Rickson, who is a brain injury survivor who basically didn't have anyone at the time to talk to. So we talked about sexual identity, and what really, really caught me off guard was the overwhelming response. The video became one of the most talked about posts in the community. It blew my mind. And why was it? Because it's subjects it's never discussed. Like, it's never discussed. People feel such a sense of relief and freedom seeing it out there, realising they weren't alone in their struggles with intimacy after brain injury. It was like we finally cracked open this topic that everyone knew was important, but no one, had the courage to bring up. It was just like this shame and stigma just sort of kept out, kept away, and it reminded me how essential it is to talk about these things. Because when we do, we create a safe space for real connection and healing. Now, these next few slides are sort of quotes that were from the videos. I won't you can read. But, this one is a nice positive one, talking about the fact that, her hubby was really good. But yeah, of course, that whole identity was affected. Again, that great topic, nice to hear I'm normal, and again, that worry for that other person, because just like with brain injury, all the loved ones that are affected. So certainly as well in the sexual side as well. We talk about this in that, we do talk about that we're sexual, and we shouldn't be ashamed of that. We have to try new things, because the normal things as such, or the things that we experience pre-injury don't necessarily work. Even from a cognitive issue, even if I didn't have a physical issue, there's still a whole lot of, sensory overload, fatigue, all that kind of stuff. So, making sure that it's really, really important. This is a bit of a sad one in that, this person had a partner and then suddenly they weren't the way they were. So, they lasted a year. And again, that's another hit and another point of failure. Something that, is really difficult, and then really difficult to actually sort of move on from there. Talking about that in regard to, someone not interested and then them leaving, and then actually sort of looking at how do you disclose, how do you even sort of get back out there again if you are feeling that isolation and real sort of disempowerment. And this is a guy, and again, dumb, but I didn't even consider, obviously, as a woman, look, honestly, pre-stroke, I was sort of like, I'm happy to pretend I'm asleep or whatever. But, from a guy perspective, taking that masculinity away is massive. And again, I never considered that. So we actually had a lot of guys really bringing up this topic, and again, feeling safe that we could. So here's what I think that, we need. Clinicians really need to take that lead in addressing this issue. It's not something that should be left, in the shadows. It needs to be openly discussed as part of the recovery process for people living with ABI. From a mental health perspective, the feeling of failure or ineptitude can completely shift someone's recovery journey from positive to negative after an ABI or a TBI. When someone feels like they're not measuring up, whether it's physically, sexually or emotionally, it takes a serious toll on that mental well-being. That sense of I'm not good enough anymore can really impact on how they approach their rehab and overall recovery. And it's something that we need to be mindful of when supporting people through their recovery and their journey. Don't say recovery, sorry. And so this is where the targeted training comes in, by helping clinicians understand, assess and treat sexual dysfunction after ABIs and TBIs, we can reduce the discomfort that often surrounds, that topic. But beyond that, adjustments need to be made. It has to be at an individual and a policy and procedural levels to ensure that this important issue is routinely incorporated into comprehensive rehab. Oh, I did it again. So, there's no doubt that discussing intimacy after an ABI or a TBI can be uncomfortable, especially when family members are present. So, think about it. If a son who's had an ABI, TBI basically wants to talk about sex in front of their mum, well, that's not going to happen. But this discomfort is so common that most of the conversations either happen because the patient is brave enough to actually talk about it, or it comes up only when there are issues or something negative like inappropriate sexual behaviour occurs. No. Sorry. But here's the question. How can that lead to a productive, positive outcome? It puts the responsibility on the person with the injury to push through their discomfort or wait until something bad goes wrong. Neither of these options set them up for success. We need to create spaces where these discussions can happen naturally without that stigma or discomfort to ensure people can be supported in their recovery. It's time to confront this issue directly and make real changes that will transform the holistic recovery for everyone affected by ABIs and TBIs. So let's ensure that no part of this healing, physical, emotional or sexual, is overlooked. Our recovery depends on us addressing every aspect head on. So as we wrap up our discussion today, I'd just like to highlight the key points. I think I've actually gone a bit over. These takeaways encapsulate the core messages of our conversation about sexuality after brain injury. They serve not just as a summary, but as a call to action to us all, survivors, clinicians, researchers and supporters alike. I hope these insights will inspire you to continue this conversation in your own work and communities. By breaking the silence around sexuality after brain injury, we can make a real difference in the lives of survivors and their partners. Thanks for your attention and commitment to this crucial aspect of recovery.
Thank you so much, Saran, for sharing your experience. It's just so invaluable. And we're going to have a big discussion session at the end, I'm really hoping, because there's a great deal of overlap in these presentations. So the next presenter is Caitlin Fulton, who's an occupational therapist with the Lifetime Support Authority here in South Australia, and she's going to present client and clinician perspectives on sexuality after brain injury.
So firstly, I'd like to take the chance to thank everyone who was involved in the study, particularly the Lifetime Support Scheme participants. During this presentation, I encourage you to reflect on your own comfort and confidence levels in relation to this topic. I'd like to acknowledge the traditional custodians of the land on which we meet today and pay my respects to elders past and present, and extend that respect to other First Nations Australians who are present today. So, we knew that serious trauma injuries may significantly impact on sexuality. Sexual adjustment can be a pivotal part of rehab success, however, is one of the least discussed issues. We were not aware of any studies addressing sexuality as part of rehab with this particular cohort. For the purpose of this study, we used the World Health Organization definition of sexuality. We understood it to include roles, relationships, body image, confidence, and how people feel about themselves. The study was completed at the Lifetime Support Authority, which is a government organisation that provides treatment care and support for participants who have sustained serious motor vehicle injuries in South Australia. Case management is provided in-house by service planners of allied health backgrounds or with significant experience in the disability sector. Service planners work collaboratively with the participant, allied health team and medical practitioners. So, the aims of the study: to examine the perspectives and experiences of lifetime support scheme participants relating to sexuality being addressed as part of their rehab, to explore the LSA service planners' knowledge, comfort levels, and attitudes towards addressing sexuality, and to explore any facilitators and barriers. A qualitative needs analysis using mixed methodology was chosen for this study, and this included questionnaires being posted out to LSS participants and interviews of service planners. Inclusion criteria for the LSS participants included a diagnosis of traumatic brain injury, spinal cord injury, blindness, brachial plexus injury or amputation, being over 18 years old and living in a community setting, and all service planners were eligible except those facilitating the study. For the analysis of the questionnaires, descriptive statistics were used, and interviews with service planners were recorded, transcribed, and collated into themes. So results for the participants: out of 87 participants who were deemed eligible to participate, 21 completed and returned questionnaires. Those who responded were predominantly male in the 18 to 29 year age bracket, and TBI was the most common injury type. So, what did we find? We asked participants what stage of rehabilitation sexuality should be addressed, and they commonly responded that a combination of settings was best. Participants fed back that feeling comfortable with the health professional that they were discussing sexuality with was really important. Knowledge levels and maintaining confidentiality were also important to them. As you can see, participant answers were mixed relating to whose role they felt it was to address sexuality. Most commonly, they reported GP, rehab counsellor, rehab physician and counsellor, but there was a mix of answers. And here is the data for all injury types compared to the group who had sustained a traumatic brain injury. And results, as you can see, are quite similar when you compare them. Almost 50% of the TBI group reported that sexuality had been affected by the injury, and this is consistent with other research into TBI addressing sexuality. Less than 1/3 of the participants advised that sexuality had been addressed as part of rehab, and the importance of addressing sexuality was slightly higher in the TBI group, but very similar. So what did the service planners have to say? Well, 10 were deemed eligible to participate, completing face-to-face interviews. The majority were occupational therapists by background. And thematic analysis revealed 4 key themes. Whole person approach. Overwhelmingly, staff reported that sexuality was often missed, but a key part of person-centred practice. Timing, delivery, and responsibility of discussions. So service planners reported that sexuality should be brought up gently and early in rehab, offered several times, and was the role of all allied health professionals. One service planner said, "I'll link it to roles, checking how things are going in all areas of life." Another said, "It's really important for us just to make sure that we introduce the topic and allow that space to have it spoken about." Culture and comfort. Some service planners worried that addressing the topic may be inappropriate or invasive, potentially affecting their relationship with the participant. One service planner said, "If the person asking the question's uncomfortable, that makes them feel uncomfortable." Another said, "The client brought up the topic because he'd received the survey, and it was something he'd obviously been wanting to talk about, but hadn't had an inroad before." and future tools and skill sets. Service planners advised that they lacked knowledge of training and services to address sexuality concerns, that it should be incorporated into existing assessment tools, and that participants required education about what supports the organisation could offer. One service planner said, "I can honestly say, I don't know how brain injury would affect sexual function." This study concurred with other studies outlining a low frequency of discussions relating to sexuality as part of rehab. Interestingly, we found the majority of participants seemed quite comfortable to discuss the topic. However, clinicians reported many barriers. These included age, so feeling uncomfortable talking to someone older than them, gender, feeling uncomfortable talking to someone of the opposite sex, and perceived comfort of participants. This study demonstrated differing views on the roles of various health professionals in addressing the topic. Service planners felt that they were quite well placed to discuss this topic. However, participants generally nominated GPs or rehab physicians as best placed, and further data would have shed more light on the reason for these responses. Although literature suggests that health professionals do not need to be the experts in sexuality, some participants felt that the knowledge of health professionals was important. And again, further research may have provided more information about this and how participants define knowledge and whether they actually expect health professionals to be the experts or rather to know where to gain basic resources and referral sources. Both service planners and participants reported that discussions needed to be offered early, potentially requiring several conversations throughout the journey. The focus on sexuality created by this study at the time seemed to have really positive and motivating impacts. And it seemed to address organisational taboo. And they were a positive sign that further implementations would yield benefits. So in conclusion, sexuality isn't addressed sufficiently as part of rehab, but it is important. Service planners lacked comfort, training and resources to address sexuality consistently with participants, and addressing sexuality should be an organisational expectation and addressed at multiple stages of rehab. And some facilitators that we found included use of sexuality-related outcome measures, increased organisational exposure, staff training, awareness of available resources, and written information for service users. And here's a QR code that you can use if you'd like to access the whole article. And, oh, I've probably done that a bit too quickly, but thank you very much. Thanks, Jenny.
So for the last 30 years at Epworth, in our longitudinal outcome study, we've been asking our patients about their sexuality, and they have told us in the majority of cases that their sexuality has, from various reasons, declined. But it's only been in the last 7 years or so that we have actually been able to do something about it, and that is because these two amazing people to my left came into my life as doctoral students, and they are going to tell you what they have done about it since then. So the first to speak to you will be Jill Hwang, who's recently completed her doctorate as a clinical neuropsychologist, and she's going to tell you about the perspectives of people with brain injury, and then I will then tell you about the work that she coordinated that was changing practice at Epworth. Jill.
Thank you, everyone. My name is Jill. As Professor Jennie Ponsford very graciously introduced me as her doctoral student, which I just submitted, yay. But essentially, we'll be doing a series of presentations between the three of us kind of going through the projects that we set upon with the goal of improving the way that we address and manage sexuality changes after TBI at Merck. So won't go into it too much, but we thought it'd be good to start from the same place of what is sexuality, understanding where we were coming from. We understand it to be a central aspect. It's a human right. Doesn't equate to being in a sexual relationship. A single person has just the same amount of right to express and experience their sexuality as a partnered person. And it's very important to always consider it holistically, maybe in the sense of sexual functioning and well-being together rather than just functioning. And what do I mean by that? So the way we conceptualized it using Verschuren's research into sexuality is it can be easy to split it up, especially because this is quite a sensitive, uncomfortable topic for many people. But if you think of sexual functioning as almost that performative aspects of sexuality, the things that people think of when you say the word sex, erectile function, libido, orgasm, those sorts of things. But really the big part of sexuality that's often neglected is sexual well-being. And I think most of you here would agree. It's the appeal, it's the satisfaction, it's the connection, it's the desire to give, the ability to say no when you want to say no, the ability to communicate what is it that you want. And so even though that's a big part of sexuality, it's not really talked about in the same breath as sexual functioning. Take your photos, thank you. So why did we decide to look at it, or why did Jennie look at it? Because we know that 2,500 Australians sustain moderate to severe TBI each year. About half of them will experience changes in their sexuality, and a large majority experience a hyposexual change. So that's a reduction in those outcomes that we spoke about in any combination, in any intensity. And that it can persist for over a decade or more. And yet we're still not talking about it. And as Saran said, we often talk about it in terms of inappropriate sexual behaviors on the ward because they're overt. You can see them. Hypersexuality, you can't. Very much like the invisible disability theme that we've been talking about over and over again in the conference so far. So the 3 projects that we'll be talking about: interviews with people with TBI, how we increase clinical discussions in ABI rehab unit, and in Ellie's project where she designed and trialed a treatment program. So that's a clinical option. So with the first project, we interviewed 20 people with moderate to severe TBI, with 11 males and 9 females, in a wide age range from 21 all the way to 82. And yes, even 82-year-olds have sex. So we interviewed them about their experiences and their needs, and then used Brown and Clark's thematic analysis to produce that thematic map, which is very busy and very big. But the point is to show how varied and how complex these experiences can be, and how they can find themselves on the journey of, their rehab journey of navigating their sexuality. It is messy. And hopefully you can see how that roadmap spells the word sex, because I put a lot of work into that. So, starting from the very beginning, right off the bat, people differ. And we all know this. Everyone is different. But specifically, we saw that they differed in how important they find sexuality in their lives, how they conceptualized what sexuality is to them. So that's what sexual literacy levels referred to, how they conceptualized what it meant to them, and also did they know how it can change after TBI? And a lot of them said, no, I don't really know actually. Like Chantel said, I'm not too sure. Actually, I don't know. By the way, the names are changed. These are de-identified names. Those are not their real names. And obviously, comfort levels around the topic about talking about it, also very different. And then moving on to the TBI, the impacts of the TBI, biopsychosocial consequences coming out of the injury, all very different. How that's impacted on their sexuality, again, all very different. So moving down into how their journeys then start to split off based on what they experienced. And we saw that 2 people had no changes, 2 people experienced hypersexuality, which was described as Tess as basically wanting to have sex all the time. Sometimes it's like 3 or 4 times a day, which is a big change. And hyposexuality that was experienced by 16 people of the 20 we spoke to, which was described by Mark as confident as I was back then, I'd be pretty brazen about getting sex, but now I couldn't. I don't know how to broach it. I think a lot of that is obviously to do with my own self, just confidence and worth nowadays. Now, despite their journeys diverging, there were commonalities. First, sexuality being rarely addressed by the treating team. Like Linda said, no one questioned me about it and said, you may feel like this. If you do, let us know. None of that, which is kind of what's around. Yeah, she's nodding. And then we have an interesting one, which is that we saw that sexuality had a lower rehab priority for a lot of people, especially early in their rehab journeys. Like Kate said, I didn't really think about sex too much. I was more focused on my brain function, returning to work, being able to study, being a part of society. And I think that speaks a lot to the conditioning of what we see ourselves as humans, right? The value of us is to do things. And if we can't do things, then who are we? And so that tends to take priority at the beginning. But I want you to remember this quote because Kate is going to come back up in a very special way. Now, in terms of how they diverged, with the hypersexual changes, or the people who did experience hypersexuality, very happy and unbothered, not seeking help. But with the people who experienced hyposexual changes, that's where you see more of that sense of loss, that sense of resignation, the needing help but not knowing where to get it. But again, it's very varied. Some people were like, yeah, I'm pretty okay, like it's just what it is. But for a lot, it was a huge loss. And that brings us back to Kate. So before I asked Kate this question, she was like, yeah, I was just, I had different priorities, it's fine. Didn't bother me that we hadn't had sex 6 months after my brain injury. My husband was just taking care of me, we were good, it's fine. But then when I asked her, well, what was it like for the first time being intimate again with your husband since your injury? She said this. She said, it was like, to be honest, old Kate was back. I remember laughing, and the next day I sang again. I hadn't sung for a long time, because I remember my kids actually said at the time, so nice to hear you sing again, Mum. So obviously, I really did feel normal. And I think that speaks a lot to this idea that we don't really treat it as a rehab goal. And no one knows to make it a rehab goal, not even the person you're speaking to. But sometimes if you ask the right question, you get this beautiful response. Yeah. And then, moving down the roadmap, we have how clinicians can help with post-TBI sexuality. Obviously, many benefits and also possible barriers. One of the benefits, as Saran has mentioned, is the normalization. Like Tess said, I was given the booklet from the OT and I have a read, and I was like, yeah, okay, I'm not weird for being hypersexual. And then in terms of barriers, one of it is obviously the big discomfort around talking about sexuality, but not just from the people with TBI, but their perceived discomfort from the clinicians that can also put them off. So like Rachel said, the clinician didn't seem to be deeply interested in that, maybe even a little more embarrassed than deeply interested in it. So there's a lot of discomfort to unpack in this space for both sides, for both parties, really. In terms of preferences for service needs, again, very varied in terms of, well, what's the best time, what's the best mode of approach, who should initiate, and it was a mixed bag, which Caitlin, talked about. But timing, so Paige brought up a really good point about when the best time is. She said any time before discharge, so they understand they're getting out of hospital, so they need to understand what happens in the real world. And in terms of a big kind of preference around, or shared preference around how to broach it, seek permission. As Xavier said, just smile and ask them and say, I'm going to do this, and would you be comfortable? It's okay if you say no. So just explicitly providing and asking for permission. So that's the big map. Now the key takeaways, I guess, is that every individual is different, and that's pretty much person-centered approach, and that's for all rehab, all rehab approaches and what we try to do. But the main thing to remember that's different from a lot of other rehab goals is that it's rarely addressed. as a clinician, if you bring it up, it's very likely that you might be the first and last person to ask them about this thing that no one asks them about. That sexuality tends to be low on the rehab priority list, but can be seen as part of returning to normality. And that low sexual literacy in our society just could mean that there's a lack of language to communicate sexual issues with health professionals. So sometimes you do need to approach it from different points, like self-esteem or body image and other things, and find your in, like Caitlin had highlighted before. And so that was the first project in our series. Now I'll hand it over to Jennie to speak about our study at the ABI Rehab Unit. Thank you.
Thanks, Jill. So I'm the lucky one that gets to talk about this, but Jill really drove this next phase as well, although we kind of worked on it together, but she's been a real driving force. What we wanted to do, firstly, before I start, if you're a clinician, can you put your hand up if you do talk to your clients about sexuality? And if you are a person with brain injury, did someone talk to you about sexuality during your rehabilitation journey? Oh, well, that's actually better than when that's not bad. But anyway, it'd be nice to be seeing many, many more hands. Anyway, so this was our attempt to change practice at Epworth Healthcare in Melbourne, trying to promote team-wide behavioural change whereby clinicians would attempt to address post-TBI sexuality with patients more routinely. So, what we did, we knew we had to work with the clinicians collaboratively to achieve this. So we ran 2 series of focus groups with the clinicians across all disciplines. The aim of the first set of focus groups was to identify the barriers and facilitators and areas that they saw as being important for development. And then in the second set of focus groups, we co-designed with them some solutions to those challenges. And throughout this period, which spanned a couple of months, there was a constant checking in process with the clinicians about how they were feeling about what we were doing. And Jill actually mapped the transcripts and the whole process using 2 co-design frameworks. So in the first focus groups, we asked the clinicians firstly to write individually on cue cards what they saw as the major barriers to talking about sexuality. And then in a group exercise, these were written on the board, and the clinicians had to put post-it notes where they thought were the most important areas, either individually or institutionally, that needed to be addressed. Jill analysed the transcripts from these focus groups using thematic analysis and generated this thematic map. So the 2 major themes that we saw were the team's concerns and confidence in initiating change, which was seen to be influenced by whether they felt that changes that they made would actually be sustainable. And then there were 2 major sub-themes in that staff members clearly felt a certain degree of discomfort around speaking about sexuality, actually quite significant discomfort, more than they probably were willing to admit. And also that it wasn't always a priority in the early stages of rehabilitation, or certainly not something that was spoken about as a priority. And another issue that was raised was there was a lack of pressure from within to make change, that changes generally tended to be made in response to external pressures. So in the next set of focus groups, we had identified 5 key areas that needed to be addressed. I'm having trouble with my focal length here, but from my memory, they were that we had to look at roles, we had to conduct training, we wanted to design some resources, and we wanted to look at the case conference format and look at who delivered what within the team. So they split into pairs and using butcher's papers documented what they saw as the who, what, where, why, what and when of how we would do each of those things. And that was then relayed back to the group. And summarising all of this, Jill then moved on to create the resources and make it all happen to make these changes. So the first thing she did was designed a patient brochure that is now routinely given to every patient before discharge by the social worker. There was also an infographic for the staff, just giving information about sexual changes after brain injury and identifying the pathways that they should take in referring and dealing with any issues they encountered. We made some structural changes to the case conference format such that the case so that sexuality was routinely mentioned and discussed, and it was a designated item on the case conference record form. We also had to identify champions within the team who would be willing to routinely discuss sexuality. Fortunately, and with probably a lot of encouragement from me, the neuropsychologists stepped up and have become those champions. And then finally, Jill and I conducted training with the staff. And the training was about not only equipping them with knowledge and a whole lot of case examples about the types of sexual difficulties that people encounter, such as you've just heard, but more importantly, giving them a chance to discuss their discomfort and where sexuality could get raised within their discipline. For example, the context of physio or OT or psychology. And then we role-played, gave them opportunities to role-play. First, we sort of gave them some scripts and then they role-played amongst themselves, because it was about overcoming that incredible fear of how do I say the S word with my patients. That is still a big issue, I think, to this day. So sorry, I should have gone on to that next slide. So overall, then we needed to know whether we were having an impact, and this is a beautiful piece of work that Jill's done in that she surveyed 48 patients before we did this implementation exercise, and then another 33 afterwards to find out what had changed in terms of whether sexuality was getting discussed with them and what they thought about, what were their views about the extent to which sexuality was being addressed with them. And in fact, she found that there was a significant increase in the frequency with which sexuality was raised. It went from 16.7% to over 56%, which was very exciting. And that there was also a significantly greater sorry, I just really can't read these slides. A greater likelihood that sexuality would have been addressed with them. And then they were also asked about what sexual difficulties they were experiencing, and basically they were very similar across the groups, that the majority were experiencing a decline in their sexuality, a decline in the quality of all of their sexuality experiences and support. So we also asked the clinicians what they thought, and there were 22 surveys completed and 15 qualitative interviews. And there was also, from the perspective of clinicians, a significant increase in the importance that they assigned to sexuality. And in the qualitative interviews, there were a number of themes that they needed to... they had really, their attitudes had changed in that they really saw sexuality as being much more important. It was seen as being much more on their radar, and they generally felt that it was being discussed much more within the team. On the other hand, there was still evidence that there was lingering discomfort, and there was a sense that although their knowledge had increased, their actual extent to which they were following through with the changes we'd implemented was probably lagging somewhat behind. So overall, the key takeaways are that sexuality, we really do need to be talking about it a lot more, that we can, with this type of intervention, achieve significant change, but that we felt that it was very important that we might have, we need champions within the team to carry this forward. There are going to be changes in staff, and we feel like it's going to have to be an ongoing process, and if you are going to do things like this, you have to kind of build it in to the ongoing continuing education within the institution. So that's it for the second component. But the final component, because a lot of the issues the staffs raised were around, well, it's one thing to raise this issue, but then what do we do when they tell us they're having problems? We don't feel competent to address them. So we felt that we also had to create an intervention. And so this is what Elinor Fraser took on as her doctorate, the development of a cognitive behavioural intervention to address sexuality, which she is now going to present to you.
Thanks, Jenny. Good afternoon, everyone. So my name's Ellie. I'm a clinical neuropsychologist and a researcher from the Monash Rehabilitation Research Centre. And today I'll be talking about the design of a new psychological treatment that we developed for adults with traumatic brain injury experiencing changes in sexuality. The treatment is called CBT-SWEL, which stands for Cognitive Behaviour Therapy for sexual wellbeing after traumatic brain injury. And today I'll talk about CBT-SWEL, go through a brief case example and some of the key findings, and finish with some conclusions and, for clinicians, some take-home messages and resources. So the intervention consists of 8 sessions with a clinical psychologist and 1 booster session 8 weeks later. Participants could attend sessions online or face-to-face, and if they had a partner, they had the option of attending sessions together. The treatment was personalised, starting with a comprehensive assessment of the presenting problem, which informed the development of a shared formulation around what was contributing. This was followed by a collaborative goal-setting process, and then the delivery. So we developed 12 modules, and these were flexibly selected and delivered in a way to ensure that the content was always meaningful, relevant, and tailored to the person. Each module had associated resources, worksheets, and handouts. And a total of 16 people so far have completed this treatment. The age range is between 26 to 64 years old, and they've ranged from 10 months to 33 years post-injury. 6 people had a partner, although only 3 chose to complete the treatment together. And we used a single case series design, which allowed us to look at how participants' satisfaction with their sexuality changed over time at an individual level. To illustrate the diversity in the presenting problems, I wanted to share some quotes from individuals with lived experience who completed the treatment. So one participant identified behavioural changes as having a significant impact on their sexuality. They said, "My brain doesn't process things the way it used to. I get angry very quickly, but I don't get physical. I emotionally explode. The damage done is phenomenal." Another shared their struggle with the relationship intimacy, saying, "A year after the accident, we tried a couple of times. Nothing happened. We thought, oh well, that's a side effect of the drug, so we just put it in a box." Psychological challenges were also common, Someone saying, I felt like there was a disconnect between my body and me. I did not feel in touch with my body. I wasn't like that sexual awareness. There's no urges, and no, I wanted to be disconnected with my body because I hated it. And then sensory changes. So this person's saying, sort of my wife's smell used to hit all the right points, but it's gone now. I don't have any of those triggers anymore. This slide is illustrating sort of the diversity in goals that participants set with the psychologist. And you can see that the majority of goals actually fell within sort of this communication and relationships domain, followed by knowledge, and then sort of looking at sexual function, so looking at desire, arousal, and orgasm. That was then followed by self-esteem and body image, and sort of managing TBI symptoms was also relevant. So I wanted to briefly touch on and speak to one of the 16 cases from this project, and I've used pseudonyms. So Aidan's partner, Maddie, had taken a significant caretaking role during his recovery. And as they came up to a year post-injury, it was Maddie who was struggling with low desire and arousal, and they felt this was impacting their relationship significantly. Meanwhile, Aidan was struggling with self-esteem and difficulty communicating his sexual needs. In addition to improving their comfort and communication around this topic, a core part of their treatment experience involved teasing out the meaning of sexuality and how intimacy extends beyond sexual intercourse. After their treatment, the couple reported that working collaboratively with the psychologist helped them to navigate these issues, and they liked that the treatment wasn't focused solely on, sort of quoting, getting their sex life back on track. So for those who aren't psychologists, you may be wondering, I guess, what CBT is, or Cognitive Behaviour Therapy. It's a goal-oriented form of psychotherapy that helps individuals to identify and challenge negative thoughts, patterns, and behaviours, and replace them with sort of more positive and constructive alternatives. There's also a significant psychoeducation component. I thought it would be good just to reflect how participants sort of summarised sort of the experience of CBT. So one person saying, I think just taking a step back and looking at things from a different point of view. Another, you do need the other person to tell you, hey, try and look at it this way. Maybe it's not that, maybe it's this. And so kind of like analysing why I felt a certain way and looking at not only the negative side, but the positives as well, and kind of outweighing or weighing up both. So this slide highlights some of the strengths of CBT Swell, using quotes again. So this sort of is emphasising the person-centred approach. Participants appreciated sort of the non-judgmental, safe and welcoming nature and demeanour of the psychologists, as well as the flexibility of the program. Many people did enjoy and find the handouts helpful, and felt that they anchored them sort of during the 8 sessions to different topics or points of exploration. Interestingly, a lot of people initially struggled to identify what was unhelpful or what they didn't like. As we've recruited and more people have gone through the treatment program, I think we've identified some really nice points of feedback and considerations for us to take forward. So for example, for one person, they felt the sessions were too long and they struggled to concentrate for the whole hour. A few felt that the handouts were perhaps too simple or basic. And for one person, they felt that it was a little bit generic and lacked sort of targeted treatment to their specific issue. And one gentleman with long-standing erectile dysfunction was disappointed by the lack of immediate change or improvement in his sort of perceived performance. So at a group level, these graphs, I guess, illustrate treatment response on our primary outcome measure with higher levels or ratings indicative of greater satisfaction with sexuality. And we found that 3/4 or 75% have showed a positive treatment response on this measure. What's not shown here is that all participants recorded at least one improvement in at least one of their goals, and we found sort of some nice positive effects on some secondary measures as well. So to conclude, I guess there are a couple of key takeaways. The first being, and it sort of echoes the other presenters today, that each person's journey will be different. And whilst we have developed a program or a treatment that is quite flexible and is designed to be sort of quite person-centred, there isn't and shouldn't be a one-size-fits-all approach. And it's really on the clinicians, the teams and the services to address this topic. And there's quite a bit of improvement to be done in the area, which is why we wanted to put together, I guess, a little bit of a how-to or a guideline for clinicians in the room. So this just goes through the who, the what, the when, the where, the why, and the how. And whilst I don't have time to go through each area, if you would like to access it in the form of a handout, along with a measure, the Brain Injury Questionnaire of Sexuality, and some additional resources, you're most welcome to. And please get in touch as well if you have any questions. Thank you.
Thank you so much. We were really hoping to have a whole lot of discussion, and we're just about out of time, but could I just maybe take a handful of minutes to seek any questions, feedback, and I'm going to need someone to hear them because I'm not going to hear them. There's someone over there. Can you listen carefully to what they're saying? Okay. And answer.
Hi. So I had a mild brain injury 2019. I'd actually never heard that sexual stuff was even relevant, so it's been really informative. But my question is around, I guess, do you guys include sexologists or sex therapists in all your research, or do you have someone on board, or how does that cross over, I guess? Because I'm just, yeah.
Yeah, it's interesting. We have considered that, but to be honest, it's just really common sense psychological stuff that is much more what is needed. And there are definitely psychosexual exercises that are undertaken, and the therapists are certainly comfortable about talking about sex, but we haven't felt that was necessary so far. Would you say, do you have any more comments to make about that? Yeah.
Yeah, I guess we struggled to find, if there's a sexologist specialising in brain injury, we absolutely would, but I think, where we're positioned and where we're based, we felt that a clinical psychologist, who had experience in working with, these issues, but also, a great deal of expertise in a brain injury sort of cohort would be most or best placed to sort of, deliver the intervention. But I think would love to sort of work towards bringing in sort of different disciplines as well, like a sex therapist.
It's not that we're not open to it, but knowledge about brain injury is an enormous amount of the part of the equation as well, and a regular sexologist wouldn't have that. So, yeah.
Sorry, I guess just to add on, I was just thinking about it because you were saying that some people said that it was very generic. That's just why I thought with a sexologist or sex therapist, maybe they had that crossover to bring in some different perspectives or ideas that actually could relate to it or help it.
Yeah.
Absolutely, yes. No, I think where we are hoping to head towards is a multi-D sort of approach. So not just having one discipline, but really sort of bringing in specialised teams. And I think you're absolutely right. There's, the 25% who perhaps didn't show that change on our primary outcome measure. Perhaps, there's a better placed discipline or sort of professional who can sort of really target and hone in on their issues.
Just one more. Sarah, someone over.
I might just add to that. We have someone who wants the mic over there, but while you're passing it over, I think one thing to note as well was when we were doing a lot of the work with the ABI rehab clinicians in talking about barriers, a lot of them were like, oh, I think that's a specialist issue. And so there's a bit of a tug of war in terms of whether is it a sexologist issue or is it a multi-D issue? And I think there's space for both. And they need to work together, but not just see it as a specialist issue and too hard to touch. Sorry.
Hi, thank you for your talks. They were amazing. We have a sexologist. She works in the sex health clinic at Bowen Health in Geelong, and she's just amazing with our clients who we can refer to. Of course, we can do all the other work around intimacy and changes in body image, but we also have clients who have difficulty actually engaging in the intimate act itself or finding ways to be intimate or just other things. So she has a wonderful knowledge about sexual positions, sexual toys, and really great knowledge about which toys work for which problem. So, you know, she's just invaluable to our work that we do with clients. Yeah. So I really recommend a sexologist or someone with that level of knowledge.
Yeah, completely agree. I think the issue as well and I think that's what we want to work towards as we grow sexuality research in this field. Firstly, it's not well funded, right? And then we need to find the expertise, and then we need to be able to logistically put together all these people in a room and where they're willing to take time out of their lives. And so it's definitely like an ideal goal, and that's where we want to work towards. But at the same time, realistically, what can we do right now instead of waiting for ideal situation? Let's get it started. So I guess what this research has really represented is it's the first step.
Yeah.
And then like working towards bringing more people in with that expertise who are interested in building that within brain injury as well.
Yeah. My second question, speaking of funding, because we're neuropsychologists,
Cool.
Does TAC fund interventions for sexuality?
Does TAC fund interventions for sexuality?
They would, they would certainly at an individual level be funding that, yes. But by a psychologist or by a regular therapist. I'm not sure that I don't know that they'd fund going to a massage parlour, for example, but they will fund clinical interventions, I think. I don't know.
So,
but they have been very supportive of this research, and we have presented it to them, and they're not explicitly funding it, but they're indirectly funding it in that they fund the longitudinal study and various ways. But further to this thing about funding, it's a nightmare. I submitted for clinical trials repeatedly to NHMRC. It just doesn't even make it to the panels. They just don't think it's a priority.
I'm going to quickly jump in. I get research because I'm involved in research. From a survivor perspective, it's like anything. I've tried all sorts of therapy, and it's only actually been recently that someone sort of said, "Have you seen a sexologist?" And then I actually spoke to someone. So it's actually, unfortunately, navigating your own way. But certainly, I think I heard somewhere that research to be active can take 7 to 17 years to actually be put in place. So it's kind of like we don't really have that much time. So we need to, unfortunately, sort of find our way, and that's either by speaking to other people with lived experience or speaking, if you've got a really good therapist of any sort, like my EP was the one who sort of told me about it. So yeah, unfortunately it's our investigation that we have to do. But it would be funded as well, by the way, because I've bought sex toys and stuff, so yeah.
Hi, I was just going to add from a Lifetime Support Authority perspective, which is the equivalent of TAC in South Australia. We would fund specialists to work with participants or health professionals to support them around sexuality following a motor vehicle injury, like a brain injury. The challenge that we have is actually finding the specialists in the area to work with them. There's a real gap there, so yeah.
Absolutely. I will draw that session to a close, but I'd like you to join me in thanking you, all these wonderful speakers.